Good morning, everybody, and thank you all for joining us today for our annual National LaTrobe seminar. I'd like to begin by acknowledging the traditional owners on the land where we meet today, which is the whole of Australia, especially relevant this week as it is NAIDOC week. I'd like to pay my respects to elders past and present. My name is Laura Jones, and together with EJ Furphy, we make up the Victorian Support Nurse team. This year marks a special milestone for the LaTrobe seminar, which is usually held at LaTrobe University in Bundoora. It's its 18th year. Whilst it has been a challenging year, especially here in Victoria, a silver lining is that we're able to bring this seminar for the first time nationally to other states. Happy 18th, Miles. Like many of the kids that are turning 18 this year, birthday celebrations have been a little bit different. In session 1, Professor Prince will be giving us an overview of myeloma and an update on new treatments. Session 2, we'll be answering your questions in an interactive Q&A. If you would like to submit a question, you can do it by typing your question into the box below this screen on the website. If due to time constraints we don't get to all the questions, we will endeavour to answer them in coming days via email. We so very much appreciate those who complete evaluation forms at the completion of our seminars. Your feedback is valuable, and we want to ensure that we're improving and delivering the best online seminars that we can. This seminar will be recorded, so if you need to pop away or you're unable to make it to the whole event, don't stress. You will be able to watch this back in coming weeks on our website. I will introduce Miles, our guest speaker today. And I will do the long version because many of you have not heard him speak before. So Miles is a Professor of Medicine at both Melbourne and Monash Universities, and the Professor and Director of Molecular Oncology and Cancer Immunology at Epworth Healthcare, as well as the Director of the Centre for Blood Cell Therapies at Peter MacCallum Cancer Centre in Melbourne. He trained in Melbourne, Sydney and Toronto. He holds fellowships in the Royal Australian College of Physicians, Royal College of Pathologists of Australasia, and Royal Australian College of Medical Administrators, as well as the Australasian College of Dermatologists, and is a Fellow of the Academy of the Health and Medical Sciences. He has a very active research program involving clinical research and laboratory research, the latter involving stem cell research and cell engineering. He has been involved in dozens of clinical trials for new therapies for blood cancers, including those for myeloma. He is the chairman of our Medical Scientific Advisory Group to Myeloma Australia, is on the board of Myeloma Australia, and is the co-chairman of the T-cell lymphoma group as well. He's published over 450 peer-reviewed manuscripts and is a reviewer for numerous scientific journals, as well as a medical advisor for a variety of government and pharmaceutical bodies. Thank you so much, Miles, for joining us.
Hi, thank you so much for that very kind introduction, and really welcome to everybody to well, I hadn't realised it's 18 years. And it's interesting, we started these simply because of the development of a new drug at the time, which was thalidomide. And thalidomide was underwent its first publication in 1999. And that was driven by a patient who had found that thalidomide might block blood vessel proliferation within the bone marrow. And so she went and spoke to her doctor, Barlogi, in Arkansas at the time, and he found thalidomide for her. And amazingly, she had a response, having failed all other treatments. And subsequently, we learnt in the study that he initiated that the response rate for thalidomide was about 50% in patients who'd failed all other treatments. And at that time, all we really had was various forms of chemotherapy, particularly melphalan. And so we at the Myeloma Foundation realised that people had a thirst for, patients and carers had a thirst for, well, what's going to be new? And so with thalidomide, we started this this program of novel therapies, and it's quite amazing how many new treatments have developed over the last 18 years. and you'll hear about a lot of them today. You'll be gobsmacked about how much has changed in such a short period of time and what to expect in the near future, and really the power of science and what's going to happen in the next 20 years. So it's always difficult to give this talk. So I might have the first slide up there. So is the first slide up there? Can you just give me some feedback, Laura? Is it?
It's there.
Yep,
it's there. Thank you. I just can't see it. Just let me get to, I'm just going to make some adjustments here, everyone. Sorry. Good. Okay. Just opening my screen. Just give me a, good. Thank you. So the most important aspect of myeloma is that it is a disease of the bone marrow. It's difficult to give this talk because there's patients who are in the audience and carers who were diagnosed really within the last couple of months. And there are those of you, pleasingly, who've been coming to these since the beginning. And there's patients who've been coming here for well over 10 years. So I'm speaking to a very broad audience. So please forgive me if you've heard some of this before. Just bear in mind that there are people who have a thirst to know more about myeloma per se, and before we talk about the treatment itself. So it's a disease of the bone marrow. The bone marrow is fundamentally in the vertebra and in the pelvis. And most importantly, as you can see in the middle there, it's in this honeycomb of the vertebra. And if you can imagine, the vertebra is like a honeycomb stuffed with red cells and white cells. And what happens is that you can see the myeloma abnormal cells there, which are called plasma cells. They look like those purple fried eggs, and they're proliferating. Those cells don't want to die. And I'll come back to the growth of plasma cells shortly. But fundamentally, it starts as these little clusters and then can progress, if you can see there in the bottom right-hand corner, and actually take over the bone marrow and cause weakness and potentially fractures. Next slide. And so the problems with myeloma is that these plasma cells grow and can damage the bone, but also these plasma cells produce these proteins. And you can see a cartoon of it there, that those proteins are like fork-like proteins which bind onto a target. So for example, if you have a tetanus vaccine as a kid, and then 10 years later you stand on a rusty nail, your white blood cells get all excited and they produce these fork-like proteins, and they bind, plasma cells produce these and bind onto, in this example, tetanus, and they kill them. Now, what happens in myeloma is that you're producing excessive amounts of abnormal protein, these abnormal antibodies. So it's a bit tricky in terms of the naming of all of this, because when we think of protein, we think of meat protein or what we eat, but these are actually, most of the proteins in our body are tiny and microscopic, and a lot of them are these antibodies. So this is the abnormal protein that we talk about in myeloma, because they're being produced by the plasma cells. So as we kill plasma cells, those protein levels will fall. And so it becomes a barometer of how we monitor the disease. Next slide. So can occur with myeloma. You can see the abnormal protein at the top, you can see the bone disease at the bottom, but also you can get kidney damage because of the abnormal protein or high levels of calcium. Next slide. And ultimately, what can happen is that you can get failure of the bone marrow as those plasma cells grow out the bone marrow, leading to the risk of infection in particular. Talked about kidney problems, and when it involves the bones, you can develop bone pain, and then calcium can leak out of those bones, and you can have high calcium levels. Next slide. So that's how patients with myeloma typically present. And the average age of myeloma is 65. That means that half the population of myeloma patients is below 65 and the other half is above 65. And so it's really important to recognise that treatments are designed for that age group. And so when we talk about all of these novel therapies and the new treatments, I'm talking about it in the context of really being able and suitable for patients who are in that age group. So unlike other cancers which may afflict younger people, like some of the lymphomas, where we're applying standard treatments for lymphoma to older patients, these are really treatments that are designed for this age group. And so we have to bear in mind not only the importance of the effectiveness of the treatment, but what is also critical is the potential side effects, because side effects can be more difficult to manage if you're older. We don't know really what the cause of myeloma is, except to say that it's really a disease of the Industrial Revolution. It's really accelerated since that time. And all of the below listed there have been suggested associations, but none of them are clear. I would say that I've only had 1 or 2 patients in my entire career where I've said, this is likely the cause of myeloma. In those situations, it was actually pesticides. But most people don't have any known exposure. What we know is it's extremely rare to be in families. I'll come back to that next slide. So its incidence appears to be stable, bearing in mind the aging population. So if you compensate for an aging population where myeloma becomes more common as the population gets older, if you look at it across the board, it doesn't appear to be increasing. The other two, the graph at the top there, are other types of blood cancers, such as follicular lymphoma, which have been increasing. So myeloma seems to be fairly stable, but there are reasons why in some situations it's increasing. Next slide. And in fact, in Australia, it is increasing, but that's largely for 2 reasons. One is better detection, because we have such a good healthcare system. People are being screened more and it's being picked up earlier. And the second reason it's increasing is because of an immigrant population and over the last 30 odd years. Because if you look at that slide, you'll see that in Europe, particularly the Mediterranean basin, seems to be emphasized. That's what's in red up there. And we believe that there is some ethnic association with myeloma, particularly in the Mediterranean, the cause of which remains unclear, but there is not a very strong familial association. It is the most common blood cancer in Black Africans, both in Africa itself, particularly South Africa, and also in the United States of America and Canada. So it's a very unusual combination of ethnicity and genetics. Suffice to say that in Australia, we are leading the world in terms of new diagnoses, and that's a combination of those 2 things, particularly good testing. Next slide. So when we think about myeloma, this is how we've classically thought about it, and I'll spend a little bit of time on it. It starts off, if you can see in the top there, what we call asymptomatic, which means no symptoms, where the disease is growing in the bone marrow. And it starts off as really slow-growing plasma cells in that bone marrow, which are really not doing anything. They're like little snipers in the tree. They're there, but not causing problems. And then what happens over time is that those plasma cells grow and it develops into what's called symptomatic myeloma, or active myeloma in yellow. And that's because those plasma cells are growing and bone marrow or kidney problems or calcium problems may occur. And that requires treatment. Then what happens is patients have treatment and then they go into what's called a remission, there in yellow, or otherwise cause a plateau, where the protein levels flattens out, and that's because the plasma cells are at very low levels. And then the myeloma fundamentally is asleep, what I would describe as a bit of a sleeping bear, because one day it will grow, it will start to regrow and wake up. And we don't know why that happens, but that plateau phase is quite variable. And what we know about that plateau phase is that generally the better the response, the less myeloma we achieve with the frontline treatment, the longer that plateau will be and longer time before the disease starts to regrow. Then we retreat and we go through the same process. And in the olden days, 20 years ago, when all we had was chemo, those plateau periods, remission periods, were generally shorter, got shorter and shorter with each cycle. It's not so much true now because of the different ways in which we can kill the myeloma using not just chemo, but some of the new agents which I'm going to talk about. Each of those plateau phases can actually be just as long as the first one, and in some cases, even longer, because unfortunately, we cannot predict yet which patients will respond to which therapies in a great deal of detail. And so some patients will have a bone marrow stem cell transplant and they'll remain in remission for 4 years, and then they'll go on to their next treatment and they may remain in remission for another 4 years or maybe even 6 years. So as a general rule, we do consider the shortening of plateau as we move along, but it's not always the case. Next slide. So in the days before new drugs, the issue was that we really had to balance up when should we treat the patient, because sometimes the treatment was actually worse than the myeloma symptoms itself. In other words, we would see the protein levels go up, patients weren't having problems with symptoms, and we wouldn't want to give them, say, more melphalan and the side effects and the toxicities of the chemotherapy. But now what's happening is that as we're getting newer drugs and better tolerated drugs, we are tending to treat the disease a little bit earlier before symptoms develop. And the beauty about some of the new testing of myeloma, particularly the new scans, things like MRIs, PET scans, sestamibi scans, and the new types of CT, is that we're getting better at following the myeloma and working out when is the best time to treat. Next slide. So in general, we divide patients up into 2 categories. Patients who are relatively young, and as a general rule, we would say less than 65, often less than 70, and sometimes even less than 75, who are what we would consider well enough to have a stem cell transplant. We call them stem cell transplant candidates. And then there are non-transplant candidates. And so when I see a patient, they walk into the room and we're talking about it, the first thing I'm trying to assess from the history and looking at them and the story is how physically fit are they? What is their capacity to undergo the treatments that we offer the patients with myeloma. Next slide. So in terms of the development of treatments, this is really a timeline, and I just want to focus on the fact that it's really been, as I said, 1999, smack in the middle there, that we have thalidomide. And then we've had these new developments of drugs. Every few years, we've had new drugs develop, and I'm going to come back to this slide along the way. Next slide. So what are the overall treatments that we have in myeloma? We have supportive treatments. Sometimes we use surgery. For example, if someone has got a fracture in their arm, we put a pin in. We definitely strengthen the bones with what are called bisphosphonates, bone strengtheners. We use chemotherapy, predominantly in the context of the high-dose melphalan with the stem cell transplant, but we use other drugs such as chemotherapy. So such as cyclophosphamide, melphalan and cyclophosphamide are common. And then there are these non-chemotherapy modalities, and I'll spend a minute or two on this slide just to give you an overall picture of what I'm going to talk about. So don't get scared that you haven't remembered everything, because we will be talking about it. So there's this group of drugs which we call the IMiDs, which are the immune modulating agents. These are agents that stimulate our immune system at the same time as killing the myeloma cells directly. The first one was thalidomide. And these work by boosting the immune system, the body's own immune system, to kill the myeloma. Then after thalidomide, the next generation was lenalidomide, and its trade name is Revlimid. Then there was pomalidomide, and its trade name is Pomalyst. So every drug has a nickname which can vary, and depending on the number of companies that produce it, there can be a number of names. But at the moment, lenalidomide is called Revlimid, pomalidomide, Pomalyst. And these fall into this family of immunomodulatory agents, which lenalidomide and pomalidomide are about as effective as each other, but they have slightly different side effects. Then there's this other group of what we call proteasome inhibitors, and I'll come back to that what they do. But ultimately what they do is they teach the myeloma cell to commit suicide. So one of the problems in myeloma is the fact that the cells refuse to die. So we used to think of cancers purely as situations in which cells simply multiply rapidly. 1 makes 2, 2 makes 4, 4 makes 8. Whereas in blood cancers, as a general rule, it's not just that proliferation, but in fact, almost more importantly, is the fact that the cells are sometimes often immortal and they won't die. So that cells should be like a leaf on a tree. They should, after a period of time, go brown, so to speak, and fall off the tree. In other words, die after a few months. But what happens in the plasma cells of myeloma is that they learn to be relatively immortal. So that's driven by this thing called the proteasome, without going into too much detail. And there are ways in which we can teach those cells to commit suicide using these drugs called proteasome inhibitors. And one of them is called bortezomib, and its trade name is Velcade. And there's another drug called carfilzomib, and its trade name is Kyprolis. And both of these are of the same family, and I'll come back to that. Then there's this group of drugs called monoclonal antibodies. And these are antibodies that are developed by pharmaceutical companies in the test tube, and they're produced as pharmaceuticals. But fundamentally, they work like antibodies. They bind onto the outside of the abnormal cell. So just like a normal antibody might bind onto a bacteria or a virus, these antibodies have been designed so that they bind onto the target cancer, the surface coat, and I'll come back to that. And the current ones are listed there. Daratumumab is the main one that's about to be approved by the PBS, or it has been approved by the PBS, and is about to be used more and more in the community, and we'll talk about that. Then there are other immune therapies, what I call BiTEs, CAR-Ts, and antibody drug conjugates, and I'll talk about those in detail. And then there are other drugs which are on further trials as well. Next slide. So you're going to learn all about those in the next few minutes. So to know how to kill a cell, we need to understand how it grows. Next slide. So in short, what happens is that, I'm not sure if you can see that, if that's come out there, but what it's supposed to show is it's supposed to show cells dividing. So what happens is that when cells go from 1 to 2 to 2 to 4, or 4 to 8, they divide up their chromosomes. So the genetic material doubles. So it goes from one cell and then it doubles and then goes into the 2 cells. And those 2 cells then double and it goes into the next, etc. What happens with chemotherapy, it gets into that doubling process. And so it blocks that capacity for the cells to multiply. Next slide. So why are we looking for new drugs? Well, we're looking for drugs that have less side effects than chemotherapy. We're looking for drugs that are better, that may work better than chemotherapy, and also what might work when the previous chemotherapy has failed. We're certainly getting it better at predicting the future. In other words, looking at the individual patient and looking at their myeloma and saying, look, I think it is going to behave standard or a bit more aggressive. And so that I haven't got time to talk about that today, but that's an important development that's being made in myeloma. And we're also, as I touched on previously, getting better ways of following the disease, better blood tests and better scanning techniques. Next slide. So why do we need new drugs? As I mentioned, we want to prolong survival. Unfortunately for everyone, relapse is inevitable, and the remissions, whether they be many years, they're always too short. So we know that some subtypes of myeloma respond better than others, and in fact, some don't respond that well to chemotherapy, and we need to treat with other drugs earlier. Is there a potential to cure? Well, the cure word is certainly being spoken about, because ultimately what's happening is that we are trying to get the right drug combinations. Now, you will go onto the internet, and this is one of the things I want you to remember, is that when you go onto the internet, you'll see that in some hospitals, they're combining like 6 or 7 or 8 drugs. Now, the problem is that if you put all of your eggs in one basket, if you put every component into one soup, you could use them all up. At the same time, maybe you can cure some of those patients. And so there are very good studies that are being done that are combining a lot of drugs, but it doesn't always mean that every drug in the armamentarium must be used at the same time, because there is good reasons why we might want to necessarily spread out and choose one drug at a time. So don't think that you need to be having 5, 6, 7 drugs. Yes, it's nice to have 5, 6, 7, but probably better to have them spread out over a period of time. Although clearly there are some situations where drug combinations are beneficial. So I just make that point because a lot of people come in and they say, look, I've looked up what they're doing at Boston, or what they might be doing in some centres in the UK or France or Italy, and they're combining 5 or 6 drugs. And the problem is that they're highly selected patients on clinical trials, and combining those sorts of drugs is not always easy. And there's been a number of studies which have shown that the toxicities of making too many drugs in your soup is too hard on the patients. But generally, the drugs are better. We're getting better side effect profiles. The side effects are reducing over time, remembering that we are aiming at treating patients in an older age group, and ultimately what we want to do is improve quality of life. Next slide. So just clicking through here, there's those plasma cells, those fried eggs. And if you can imagine the bone marrow environment, what happens next is that these cells, just click through this, these cells are growing in a conducive environment. They're also replicating, but also they're being pulled back by this natural cell death. The cells should naturally die, and there's also immune control. So what we're trying to do in principle in myeloma treatment is onto the next slide. If we just work through this one again, is that we're trying to reduce the replication at the top. We're trying to make the environment hostile down the bottom and draw them back. We're also trying to induce this natural cell death, push it, make the cells commit suicide, what's called apoptosis. And we're also trying to boost the immune system and therefore get better immune control, thus pulling the myeloma back. And that really summarizes really what we're trying to achieve in the environment in the bone marrow. Next slide. So I use this slide a lot because it really gives us now what are the 5 principles of how to kill myeloma. If you click on to the next slide, the first one is chemotherapy. And chemotherapy, as I mentioned, is how those cells are splitting up there. And the main 2 drugs we use are cyclophosphamide and melphalan, often in the context of a stem cell transplant, or cyclophosphamide in combination with some of the other drugs, which I'll show you. The second is to stimulate the T cells. And as I've mentioned before, there's this group of drugs called the immunomodulatory agents, thalidomide, lenalidomide, and pomalidomide, which are there to boost the immune system. Then there's ways of modifying the T cells. This is the new treatments, the ways that we can actually make the T cells in the body be pulled towards our cancer and actually activate the T cells, superpower them. And one of them is called BiTE therapies, which I'll talk about, and this new therapy called CAR T cells. Then there's our friend, the dying leaf, the apoptosis, which is Velcade and carfilzomib, otherwise known as Kyprolis. And then the concept of these antibodies, the killing them like we're smashing an eggshell from the outside. And they're what I call cold antibodies, just antibodies. They're just one antibody, and they're directed proteins on the cell surface. And that includes a drug called daratumumab, a new one you'll hear more about called isatuximab, and then another one called elotuzumab. And then we can bind these antibodies to turn them from cold antibodies to hot antibodies by attaching a drug, attaching a specific poison. So just like a sea anemone can poison a fish by going by using a specific poison, we can take some of those poisons that nature uses and attach them onto the antibody, so the antibody gets inside the eggshell and then can poison the cell in a very much silver bullet approach. And then we have what's called small molecules. Cells stay alive by signaling. If you can imagine, there a series of chemical reactions going from the front door of the cell all the way through to its central nucleus, which is where all the genes are switched on and off. And we can try and block those processes all the way through. And that's been highly effective for a number of blood cancers, such as chronic lymphocytic leukemia or large cell lymphoma. And the drugs that have been used out there are selinexor, another drug called plitidepsin, and a drug called venetoclax, which is specifically helpful for a type of a myeloma that has this genetic abnormality called between chromosome 11 and 14, and I'll come back to that. So you can see here, in the last 18 years, we've gone from one drug, thalidomide, all the way through to all of these different options and different ways of treating myeloma. Next slide. So if you work your way through this, what we've discovered is that if you're looking at a different way, in the center there is the plasma cells with all the processes, and this is a more detailed list, which I'll come to, of all the different drugs. And the ones in green are the ones that have been successful. The ones in red are the ones that have been successful. The green ones are in development, and then the black ones are in very early development. So there's a very promising future to the way we're going to be treating myeloma. Next slide. The problem is which of those switches in the cells are the most effective, and that is what clinical trials are all about. We always start off in the Petri dish, and then we treat patients, the mice patients we know, and then ultimately human patients going through a series of clinical trials. And that's how we've developed all of these drugs in the last few years. All of those drugs on the list that I showed you before of the eggshell, etc., the eggshell and the leaf, they've all gone through the same process, and we've discovered key switches. But some of them have been unsuccessful because they haven't been able to kill mice, or they've been too toxic on the patients. Next slide. So let's start talking about some of the drugs. So thalidomide is not new anymore. As I said, it's been around realistically in the community for 15 plus years. And in fact, it was first approved in Australia. It's not new anymore. It has a response rate of 30 to 50%, but allows disease stability in about the same number. So it is effective. It has an increased effectiveness with steroids, either prednisolone or dexamethasone, and so it's commonly combined with those drugs. Sometimes we can't use steroids. Those drugs will still work, but they may work a little bit slower. Because it's a tablet, it's very convenient, but the side effects, predominantly neuropathy, next slide, have been limited for thalidomide. And so the major side effects of thalidomide in this slide are constipation, sleepiness, because that's how it was developed, hand tremor, and a painful neuropathy. It can increase the risk of thromboses and skin rash and cause edema. Now, that is true for all of the IMiDs, lenalidomide and pomalidomide as well, but the side effects of constipation, somnolence, tremor, and neuropathy are much less with lenalidomide and pomalidomide. Thrombosis and skin rash are still relatively common. Thalidomide we can use across the board. Now that lenalidomide, the next generation, is more routinely available and easier to get, the use of thalidomide is really dropping. However, it can be still very useful in patients that have very low blood counts from a lot of prior treatment, because it doesn't seem to drop the platelets or the red blood cells or the white cells as much. So it won't disappear completely, but it will it's becoming used much less frequently. Next slide. So steroids, they're not a novel agent, but everybody asks about them. They can be friend and foe. What they do is that they can work very quickly while we're waiting for the other drugs to work. So they can help the kidneys and reduce pain. They have an anti-inflammatory effect, which means pain goes down. They can actually turbocharge, be synergistic with the other drugs and increase the overall response rate. And they can also be used to maintain the myeloma and continue to suppress the myeloma. But they make people hyperactive. They can cause excessive acid in the stomach. For over long term, they can increase infection risk, and they can cause the muscles in the legs and arms to be weakened. They can thin the bones, so-called osteoporosis. And the dose reduction can often improve those side effects. So steroids are important. They're never going to disappear. They're always going to be useful for myeloma, but particularly in combination. Next slide. So beyond thalidomide, I've already talked about the new drugs. Next is lenalidomide, and lenalidomide is otherwise called Revlimid. It's a derivative of thalidomide, and it has those different side effects, but it still can cause thrombosis, and it does have a tendency to reduce the blood counts, and that's the thing that we watch most commonly when patients are starting lenalidomide. It's a tablet, so very convenient, often used with steroids. The response rate is around 60%, and we can often use it with chemotherapy, although it's limited often because it causes more, the chemo plus the lenalidomide often causes the blood counts to drop lower than either used alone. So it's used quite a bit by itself with dexamethasone without chemotherapy. Next slide. I've mentioned the side effects there. If patients have impaired kidney function or renal function, then we have to adjust the dose. Now there's been some big changes in myeloma. The big change is that it can be used with bortezomib, the proteasome inhibitor, the one that induces apoptosis. So in the last year, during this year, we've been allowed to combine bortezomib, which I'm going to talk about, with lenalidomide. And so now what happens is any patient who we see, independent of age, we'll consider, should patients have lenalidomide and Velcade bortezomib together with dexamethasone, or should we use them apart? And that really does depend on age. And as I said to you before, particularly as people get older, combining agents is a bit harder. Nonetheless, it does overall, when combined, increase the response rate. We also can use it in patients who are transplant eligible now, and that's only happened this year, where we can combine lenalidomide with Velcade in the 4 months leading up to their stem cell transplant. We often use lenalidomide now as maintenance, and that's been a major addition to our armamentarium. So after patients have had their upfront treatment, whether they go to a transplant or not, they're often maintained on lenalidomide. So they can be used, maintenance can be used post-transplant. And just a plug for Myeloma Australia, through the Myeloma Scientific Advisory Group, we've been working hard with government over the last 3 to 4 years in that group to get these new drugs and these new combinations up. It's been frustrating at times, it's been a bit slow, but I think because we're the peak body that the government goes to ask about myeloma, we've been very effective in getting these drugs. Lenalidomide, it can not only be used once, but it can be used twice or 3 times or 4 times. In patients when the disease comes back, we're allowed to re-prescribe lenalidomide. And so sometimes we might use it right at the front, and then it may be the patient's 4th treatment. And often one of the things that we weren't allowed to do early on, but are allowed to do now, is give patients holidays. If we find that they're getting tired, the side effects are too much, they need a break, we can give them a few months holiday if needed. And that also may be practical if we can ever be allowed to leave the country or get in our caravans and go away. We don't always have to be on drug. And it is worthwhile asking your doctor, can I have a holiday? Sometimes it's appropriate, sometimes it's not. It's very individual. Next slide. So unfortunately, we're not allowed to combine lenalidomide with every drug. We're only allowed to combine it with Velcade, otherwise known as bortezomib. So I've mentioned the other drugs, carfilzomib, ilotuzumab, daratumumab, and the bottom one is now called isatuximab, ixazomib as well. All of these have been shown effective to combine, but it's only Velcade right now that we're allowed to combine lenalidomide with. So your doctor, if he prescribes carfilzomib to you, is not actually allowed at this point to prescribe lenalidomide because of the high cost of the drug combination. Next slide. Pomalidomide is another derivative of thalidomide, and in short, the drug is actually just as effective as lenalidomide, and in fact, in the United States, it's probably used a bit more than lenalidomide. Not because it's a better drug, it's just how the drug has been developed in the different countries. So where we use pomalidomide, it can be combined, and it's often combined with cyclophosphamide. As I said, we're not allowed to combine it yet with antibodies or Velcade outside of a clinical trial. It's PBS in Australia approved in patients that have either relapsed on lenalidomide or after lenalidomide or Velcade, or if they haven't been able to tolerate those drugs. And so it is becoming increasingly used, and it's a very good drug. It's not affected by kidney problems, and so it's very effective in that situation. And it does work, although it's of the same family as lenalidomide, it certainly can work in patients that have had lenalidomide in the past. Next slide. I've talked about Velcade already, otherwise known as bortezomib. It's the one that induces the drugs to commit suicide. It stops them being immortal. And it was originally used just in relapse disease, but now is virtually, most of its use is actually upfront, is in the first treatment, either in patients that are going to a transplant or not. And it's often used with steroids, particularly dexamethasone, and it's often used with cyclophosphamide and given for 3 to 6 cycles pre-transplant. It's used with cyclophosphamide in relapse disease, the so-called regimen called CyBor-D or VCD, and it can be used with lenalidomide, but is, as I've mentioned, just in Australia has been approved for upfront treatment, so-called RVD, in patients who are newly diagnosed. Classically, it's given as an intravenous infusion, just in the drip, over 5 seconds. But nowadays, it's increasingly used as a subcutaneous injection, i.e. under the skin, just by pinching that on the tummy or the thighs and giving that as an injection under the skin. And it's given either once a week, which is common, or twice weekly. The advantage of the subcutaneous and the weekly administration is that it reduces the risk of nerve damage. Next slide. You'll see here my little joke about the appointments, and the point of this joke really is that although giving it something over 5 seconds or a subcutaneous injection sounds very easy and simple and simplified, it still means you coming into the hospital, seeing the doctor, if needed, or waiting for the nurse or waiting for the pharmacy, or all the things that you have to put up with coming into hospital. There are a number of hospital in the home programs. It's worthwhile asking your doctor if that's suitable. And equally, there are developments of the new drugs. These drugs is in oral formulations, and there are some oral formulations available, and we're trying to get it through the PBS, but to be honest, we're not sure how successful that will be, given the high cost and the limited number of trials that have been done with the oral agents. So we'll watch this space for tablet forms, but it is exciting and eventually will come. Next slide. So the side effects of Velcade are marrow suppression, the neuropathy, which is the most important, and importantly, we can use it in patients who have impaired kidney function. So the major indications, as I've mentioned, are when it's used up front or in relapse disease. We can use it again. And now, and the big blowing of the trumpet is that it can be used with this new antibody called daratumumab, which I'm going to talk about. But it's only available at first relapse with daratumumab. So it's only as part of second-line therapy. So, for example, after the disease has returned post-transplant, or if the disease comes back in patients who haven't had a transplant for their second treatment. Now, I'll be blunt with you, that's a bit disappointing because we would love to have the drug available further down the track. Fortunately, the company that produces it, Janssen, is going to provide it through a compassionate scheme, but only after patients have had all the other treatments that we talked about, carfilzomib or Velcade, etc. So the antibody treatment's exciting, but has limited availability, but in fact is likely there are new antibody treatments coming available through clinical trials, etc., which is giving us good access to these. Next trial. So the problem with Velcade is the neuropathy. You can see here the side effect. And so carfilzomib, you'll notice the monoclonal antibody, that's what the MIB stands, not the monoclonal antibody. MIB is common to bortezomib and carfilzomib. That means that they're related. And the advantage of carfilzomib is that it has less neuropathy. We see higher response rate, but it does cause the blood pressure to go up. It can irritate the heart. It's given as an ongoing treatment. So because there's no neuropathy, people can keep getting it. And it is on the PBS for relapse disease. Next slide. And so the concept here is that the ongoing therapy works. The idea of pushing the brake and trying to suppress the myeloma ongoing. If we had a drug that had no side effects, that patients could take as a tablet and was effective in myeloma forever, we would just put patients on just like a blood pressure tablet. That's what we're really aiming for, because we know as a general rule that the myeloma clone likes to be suppressed. But the reason that we stop and start is simply because of toxicity or the potential risk of developing resistance. So most of the drug treatments for myeloma are 3 months, 6 months, 12 months of treatment and then stop. And then when the disease comes back, retreat. In some situations, particularly in relapse disease, we prefer to keep the treatment going, but sometimes toxicity side effects will make us stop that. Next slide. So I strongly recommend that you look at the myeloma website, the Myeloma Australia website, and you go there and you can find it. Even if you look in the clinicians area, you'll find our practice guidelines. Talk about the various ways in which we use treatment. So I'm not going to talk about the details of standard therapy because we're here to talk about more of the new treatments. But if you want to know the medical, how we think, how we're hardwired, go to Myeloma Australia website. Next slide. So what are the next available options? So in the next 20 minutes, I'm going to cover these. So I've talked about monoclonal antibodies in multiple myeloma. So you can see there on the left, what these are these fork-like proteins that are recognizing receptors on the cell surface. These receptors define what that cell is. So for example, a breast cancer will have a receptor which is called HER2/neu, and that's a strange name, but ultimately there are antibodies called Herceptin, named because that's what it's targeting, HER2, and that will kill breast cancer cells. But the antibodies won't bind onto lymphoma cells or myeloma cells. And so we now have defined proteins on the surface of the myeloma cells, which these antibodies are developed as pharmaceuticals to bind onto and smash the myeloma cells like we're smashing an egg. And so the antibodies that we have out there are directed against, at the moment, 2 proteins, and I'll talk about a third in a second. One is called CD38. So we have antibodies against this CD38, and that is called daratumumab. And there's antibodies to another drug, which is an antibody directed towards the protein CD38, is called isatuximab. Daratumumab, as I've just mentioned, this year has been approved to combine or add on to another drug. And at the moment, we can only, because of previous criteria, combine it with bortezomib. We can give it by itself at first relapse. We can give it with bortezomib with first relapse. It's usually combined with steroids, but doesn't have to be. But again, it's only at first relapse. There are clinical trials which combine both daratumumab and isatuximab with other agents, lenalidomide, thalidomide, pomalidomide, carfilzomib. And so it's very possible that you may be asked to enter a clinical trial that combines daratumumab with some of those other agents, or isatuximab, which combines with any of those other agents. And so that's quite safe and feasible. And now, actually, we're looking at ways of giving these antibodies not just through the drip, but as an injection under the skin, pinch of fat. And these are the new antibodies developments. And that's actually quite exciting because it means patients won't have to have long infusions. There's another protein on the surface got a strange name called SLAM-F7, and its antibody is called elotuzumab. Now, it's definitely effective in myeloma when it's combined with Revlimid or lenalidomide, and currently the company is putting that through the PBS. I don't know whether it will be successful or not because the results aren't as strong as the daratumumab-bortezomib combination. So it is very much a wait and see. Next slide. So what tricks can we do with these antibodies? And this is the thrust of the next part of my talk. We can take these antibodies because ultimately what we want to do is to get those antibodies to bind onto a target cell. So what happens is that we can modify a normal patient's immune cell called a T cell. And we've talked about those T cells or T lymphocytes. And what we do in that situation is that we perform gene therapy. We insert the gene of the receptor, and in this situation, it can the receptor goes onto the surface. So that's what's the red receptor. So that's artificially put onto the T cells in the body, and then the T cells can then go on and bind onto that cancer cell, which you can see there in the red. So what it's allowing is those little red hooks to bind onto it, and then those T cells will be dragged together with the myeloma cells, and it will kill it. We can do a similar strategy, but without actually taking out the patient's T cells, but working on the patient's T cells that's already in them by giving them what's called a BiTE treatment, which is called a bispecific T cell engager. And I'll talk about that in a second. But ultimately, it's doing the same thing. You can see that blue dragging to the red, just like in the other slide. But it's doing this because it's adding in what is basically a magnet. It's pulling the T cell by using two antibodies that are stuck together, one against the T cell, one against the target cell, and pulling the two together and allowing the cells to kill each other. And then there is the antibody drug conjugates. So you take the cold antibody, you attach a poison that I mentioned before, that then binds onto it, and you can see it's engulfed by the plasma cell. In that situation, that blue with the red little hexagonal thing on it is where is the actual toxin or the poison. It binds onto the surface, it then goes inside the cell, and that red poison is released and kills it. And that's what's called an antibody drug conjugate. So it's conjugating the drug onto the antibody. And these are the three main ways in which we're using the immune system to directly kill the plasma cell. And these are out as clinical trials going on right now. Next slide. So as I mentioned before, what we're doing, where they all fit in there is we can modify those T cells. So they're by using the BiTEs and the CAR T cells to drag the two together. We can use the antibodies. I've talked about the cold antibodies. And what we're doing is we're heating up the antibodies. And in that situation, the conjugate is not against the actual anti-CD38, but a new protein, one I haven't mentioned. I've mentioned CD38, SLAM-F7, and a new one called B cell maturation antibody, or BCMA. Next slide. So the new treatments, to summarise: monoclonal antibodies, daratumumab, we can use it. It's at first, it should say first relapse. It's used at first relapse, not first line, sorry, it should be second line, and compassionate use at the end in patients that have used up all options. Elotuzumab is going through the PBS. Isatuximab is going through clinical trials. CAR T cells through clinical trials. These bispecific T cell engagers through clinical trials. The antibody drug conjugates through clinical trials. Carfilzomib, a proteasome inhibitor related to bortezomib, is on the PBS now. Ixazomib is an oral. It's going through the PBS. There has been compassionate use. And at the bottom of there is the new chemotherapy, bendamustine, which is available, but patients have to pay. Next slide. It's not that expensive. It's moderately expensive. Next slide. So the paradigm now for the treatment of myeloma is induction treatment with Velcade, lenalidomide and dexamethasone. Then we collect stem cells. Then patients undergo high-dose melphalan, a stem cell transplant, and then maintenance lenalidomide. And that can continue ongoing. And then at relapse, generally, it's going to be Velcade and daratumumab. Sometimes we would use lenalidomide. And then at second or third relapse, these are the options we've got there: lenalidomide, pomalidomide, carfilzomib, and then clinical trials with the immunotherapy. Next slide. Next slide. Oh, sorry, stay on that one. So the previous slide was the transplant. This is the non-transplant situation. And the non-transplant situation is similar. Patients can have, but they have three choices up front. So this is a patient who might be, say, 80 years old. They can have Velcade, lenalidomide, or they can have Velcade alone, that's bortezomib, or lenalidomide alone. And then they tend to have ongoing lenalidomide. And then the same at relapse, the option to have Velcade plus the monoclonal antibody. Next slide. I'm going to move directly on to the more details about the new treatment. So classically, we've had, when we treat cancer, we have surgery, what we call a surgery, and then chemotherapy, traditional chemotherapy, radiotherapy, and precision treatments, which is some of the new drugs I'll talk about at the end, and immunotherapy. These two pillars, the blue and the green ones, are relatively new. Next slide. So the major advances towards curing cancer have basically been us understanding the genome, the use of huge capacity computers, our understanding of immunology, the development and understanding of the biological pathways that make a cell tick, and the use of things like the synchrotron to produce designer drugs. And that's why there's been the explosion, bringing all of these together. You take one of those out and we wouldn't have been able to get where we are in the last few years. Next slide. And so ultimately, one of the holy grails with treatment of cancers is precision treatment, where we can profile the patient's cancer. And then we can go to the data bank and say, this drug will work for this patient. And then we can have this very targeted treatment. Next slide. Unfortunately, that's not really readily available in myeloma. We're just not there yet where we can pluck it off. I talk about St. Sebastian, and that's really where chemotherapy, chemotherapy can be very active. Personalized therapy, where we can choose one drug, is what our holy grail is. We haven't got there yet. Immunotherapy is very, very effective, but please remember, it is not without its side effects. It's a bit like chemotherapy in that it does have side effects which can affect other parts of the immune system, next slide, and therefore cause side effects. So one of the big breakthroughs in the last few years has been the use of these CAR T cells. In the middle there is a bag of a patient's T cells. And this is used for acute lymphocytic leukemia, and it's now been approved for lymphocytic leukemia, large cell lymphoma, and the next ones that will be approved will be in multiple myeloma. But how do we get here? The key is really the basis of understanding our immune system. Next slide. And recognizing the immune system is important in surveilling cancer. That the immune system is important in our capacity to kill target cancer cells. So on the right there is a particular type of fish, and it's a jawed fish that developed some 500 million years ago. And this lamprey fish, which you can still fish for in Scotland, was the first organism that was able to recognize and remember a foreign body. As opposed to the jellyfish on the left, where everything is the same, what the lamprey has is a T cells, or these lymphocytes, the capacity to remember the immune system. And how it works is, next slide, is the concept that we have this synapse where the immune system joins together. So a T cell, which is this lymphocyte, can recognize in normal situations viruses, bacteria, and cancer. And so the T cells are constantly trying to immune surveil and kill it, and kill these bad cancer cells. Next slide. And so what happens though is that once a cancer starts to grow, it can subvert this immune system and suppress the patient's body's immune system. And so what we want to do is to try and boost this immune synapse. Next slide. And we want to be able to recognize that. And that immune synapse, this is the chemical situations and the physics that goes on behind that synapse when a T cell recognizes a foreign cell is quite complicated. But now that we understand it, and this has really developed in the last 20 years, an understanding of this is it can be modified to really, and I'll put the seesaw there, to adjust the immune system. Next slide. And so the problem is, though, cancers can suppress the immune system from attacking it. It can subvert that. Next slide. And so what it does is that it can actually push the attacking T cells away. And the reason it does that is because our normal body is trying constantly to suppress the immune system. So that's the way we're born, is to recognize things that are foreign. And if it becomes overpowered, we get autoimmune disease. Our immune system would be attacking itself. So what we do as a default position is we try to suppress the immune system. That's normally going on. And then if we get attacked, we let the floodgates open and the immune system can take over. But if it goes too far the other way, we get autoimmune disease like rheumatoid arthritis, multiple sclerosis, mixed connective tissue disease, myasthenia gravis, all of these other conditions where the immune system is attacking itself. Next slide. So this concept of the immune synapse is around having that amber, stop, green process of attacking things that are foreign versus stopping autoimmunity, keeping that balance in place. And once cancers arise, that is subverted and the immune system shuts down. And by shutting that immune system down, the cancer can then grow. And so what we've discovered is ways in which we can boost that immune system. Next slide. And they're the drugs that we've talked about. And this was the subject of the Nobel Prize winners in 2018 that made those discoveries about the immune system. Next slide. And so we can now use the immune system to fight cancer, next slide, by a variety of ways that I've already talked about. And I'm just going to focus on those. Next slide. And so we use that by CAR T cells. Next slide. So how do we do CAR T cells? Well, what they're doing there is that ultimately they are pulling together those two cells like I showed you before by putting in that green, purple, red thing that is genetically modified, binds onto the receptor on the surface. Next slide. And so these are the good guys, the Batman and Robin, and then the bad guys. Next slide. And so what happens is that, and we're doing some of this stuff in the lab, is that we've discovered how these work. Next slide. And so if you will see there that that's a myeloma cell, and this is in the laboratory, that's a CAR T cell. It binds on, you'll see this burst of red in a second, and that's it killing the myeloma cell. And so this is how the CAR Ts work. They basically are turbocharged T cells that can recognize it. Next slide. And in fact, this kapow happens more than once. So this is our CAR Ts, but you can see it moves off onto another cell, kills that, goes red. It moves off onto another cell, it kills that, and it does that 5 to 10 times. So it's a not only a kapow, but a whack on numerous sites. So we're turbocharging the immune system to kill off multiple plasma cells. Next slide. So how does it work? Well, patients, just click through this. Patients go onto an apheresis machine and have their T cells collected, click through, and then it goes into a stem cell, it goes into a culture process. So just keep clicking through that. We culture it for about 14 days. They have these receptors on the surface, which you can see there. They're now charged and ready to go and armored, and then they go back into the patient. Next slide. And so this is an infused, just like a transfusion. Next slide. So this works, and it's for acute lymphoblastic leukemia. It's approved for lymphoma, and it won't be long before it's approved for multiple myeloma. And it's what we call a living drug. It's your own T cells which are collected and turbocharged. Next slide. It can be hairy though. Next slide. Because if you overact the immune system, next slide, sorry. If you overact the immune system, you can have toxicities. Next slide. Just like poor old Saint Sebastian. Because if you overcharge it, you can induce autoimmune disease. Next slide. And so you can get things like it cause cytokine release, where you get a boost of the immune system and it can cause toxicities, and that can be life-threatening. And in early trials, less so now, patients could die from CAR T cell therapies. Next slide. And so the future really is about, in these immunotherapies, balancing the delivery, how we do it, how we give it to patients, the side effects, and of course, a better understanding about the biology of the disease. Next slide. And it's expensive. CAR T cells for each individual patient in the United States cost about $1 million per patient. That's 650,000 Australian US dollars. And the costs are going to come down with time, and they're already coming down. But by the time we develop collect the T cells, process the T cells, treat the patient, get them out of hospital, you're talking about it. You get not much change from $1 million Australian dollars. Next slide. So, are there other ways of doing it? Well, there are these bispecific engagers, which are modified T cells, which basically are, as in the bottom left-hand corner, dragging the T cell to the cancer. And this is given as an infusion or injection. Next slide. And so this is also approved in leukemia, but it also is now being used in myeloma against the protein called BCMA on the cell surface, which sits on the plasma cells. Next slide. And so how they work, you can see here, those little orange dots are the actual toxins, the poisons it binds onto, and you can see in the green dot, then it goes into the cell, and it's got a very long name there in that purple box, which you don't need to remember, but it's an approved drug. It's gone through, it's approved in the United States, and hopefully will be approved in Australia in the not too distant future. But what's happening is there's a lot of trials being done with this when it's being combined with other therapies, such as the drugs that I talked about. So what's happening now is these conjugates are being combined with Velcade, lenalidomide, etc. And so there's lots of trials around that are being used in that context. Next slide. So these are the tricks I've talked to you about: the CAR T cells, the bispecifics, and ultimately the antibody drug conjugates. Next slide. And these are the receptors on the surface: CD38, SLAM-F7, and this B cell maturation antibody. Next slide. And this is the BCMA is this target. It's different to the other ones. It's a new one. You'll probably hear the word, but basically it's only on plasma cells, and that's why it's such a good target. Next slide. And the treatments, as I've mentioned there, and the great news is this is just the modifications of BCMA. These are the tricks that the different companies are doing. You can see here, just with the drug conjugates, there's at least 3 different types. There's other ones called engagers, which are the antibody drug conjugates. That's with poison. There's 3 different types. Then there's the bite ones. There's 6 different types. And then you can see that there's 6 different types of CAR T cells. So this is an explosion of potential therapies for myeloma. Next slide. So this is taken, sadly, there's the Tigers in the top. For those of you barrack for the Tigers, congratulations. But this was a year ago when they won the last grand final. And this is the City of Hope. This is, fortunately, in Melbourne, we have the capacity to produce these CAR T cells. That's through our work at Peter Mac. But the availability for these variety of treatments is spreading throughout Australia. Next slide. But human beings have an almost infinite capacity to take things for granted, as per Aldous Huxley, because we always want more. And that's fair enough too. So there are small molecules. Remember I showed you, next slide, that are on the right-hand side affecting the signaling pathways, the ways that cells stay alive, trying to get these molecules in and block the survival processes. Next slide. And the big ones out there have been tested for a while. If you look at the right-hand side, just click through this. We've been looking at small molecules for a while. And for example, there's a drug there, I won't mention its name, but it was tested in great detail. It was hailed to be wonderful. Another one that was hailed to be wonderful, but unfortunately, keep going, others that have question marks that have crashed and burned, and they've been unsuccessful. And so not all of these developments eventually get to the clinic. Next slide. And so when we look at those black label ones there, they're all the small molecules that we're looking at. It's incredibly exciting. Just click through all of those. They're targeting different aspects of the inside of the cell. Some will be successful, some won't. Next slide. And so there's a good friend of mine, Ken Anderson, from the US, who basically talks about these pathways and enthuses a lot of people about the new treatments. And the idea is everyone rushes off. We do the new treatments in the test tube, in the mice, in the patients. And unfortunately, next slide, it doesn't, we got to pick the right horse, of course, but if you don't pick the right horse, next slide, then you get very frustrated. Next one. And ultimately, the mice don't do so well, and sometimes the clinical trials don't do so well, and we haven't got anywhere. So not everything is a success. So we have to bear in mind that, you know, curing mice does not always equate to curing humans. Next slide. So small molecules have been a challenge because there's been a lot of these that have crashed and burned, but there are some that are exciting. Next slide. And so the ones that are out there, which are the right switches that we found, next slide, relate to, this is a drug called plitidepsin. It's a tough drug to give. It hasn't been approved by the PBS. There are some compassionate but half-funded access to it, so the patient or the hospital has to pay. Next slide. And it's used in sort of 3rd and 4th line therapy for myeloma. It's TGA approved, but it's not fully funded. Next slide. You'll hear about this protein, this drug called venetoclax, and it's used for CLL, but it targets this protein called BCL2. And it's successful in CLL, next slide, by targeting and inducing the cells to commit suicide, like I've been talking about. And next slide. It works only in patients who have a certain type of myeloma. Next slide. And that myeloma is what you see in the middle there in patients who have this 11-14 translocation. You can see the response rate, the middle bar, is much higher in patients with that mutation, which is in about 15% of myeloma. So if you have the 11-14 translocation, you potentially be suitable to get this drug at some point. Next slide. So next slide. And it's now also being combined with Velcade in various clinical trials. Next slide. There's a drug called selinexor, which you may, if you go onto the web, which you will see, it's recently been approved in the United States. It's not approved here in Australia, but there are some clinical trials being developed, which look pretty exciting. It's a small molecule, it's a tablet, which kills the cell. Next slide. and it can be very effective in patients with myeloma who've had a lot of prior treatments, and it will be used in combination. Next slide. So they're the drugs out there at the moment that are small molecules. They are useful, and we're going to see more of them. Next slide. So to finish off, last slide, surgery, radiotherapy. The so-called radiation therapy is still used in myeloma. Precision therapy has a long way to go, but immunotherapy and the small molecules are really a wish to the future. You can see that there's been huge advances in myeloma, next slide, in the last few years. And I think we should all be extremely optimistic about the future. So I will leave it there and I'll hand back to Laura. Thanks.
Thank you so much, Miles. That was wonderful. Such thought-provoking slides for a lot of you, I'm sure. There will be plenty of time shortly to ask your questions, and thank you to those who've already submitted them. We will have a short break now where you can just refresh yourself on what Myeloma Australia actually does other than these kinds of seminars. Go to the toilet, make a cup of tea, and we'll see you again in a few minutes. Good morning again, everybody. Thanks for joining us for the second session today, which is the interactive Q&A. And thank you to those who've already submitted some questions. I'll get started. So we have a question from Victoria. This person wants to know, can people on treatment for myeloma safely take a probiotic?
Okay, good question. It's a common one. I think the first thing to say is for people, so probiotics are by definition a way in which we can enhance the normal bacterial growth in our gut. And so it's actually a really interesting issue around the flora of our gut. What we've discovered is that the normal flora in our gut is really important for our immune system. And everything we put into our mouth can affect the gut, what we call microbiome, which is really, the microbiome is a trendy name for saying all the different types of bacteria that float around in our gut. And so keeping a healthy microbiome seems important. And it is important because if you really disturb your microbiome, some bad bacteria grow. One of them, for example, is called Clostridium difficile, and that can cause diarrhea. So people who take lots of antibiotics can really affect their microbiome because it will kill the normal bacteria. So over the years, people with myeloma may get a lot of different types of treatment. Generally, most drugs do not affect the microbiome, but antibiotics can. There are some drugs that, some foods that can affect the microbiome. And as we have become a little bit more gentrified and our food's generally cleaner, or with the use of antibiotics in farming, there's lots of antibiotics in some of the food that we take, which can affect the microbiome. So even normal animal who is given an antibiotic as part of their feeding process, you then eat that animal, the antibiotics can go in and affect the microbiome. So there's been a lot of interest around that and how that microbiome may influence the immune system. But theoretically, makes lots of sense. Practically, taking lots of antibiotics, it makes sense. And taking a probiotic, which is basically bacteria. So the classic probiotic is like a yogurt-based, and that has the bacteria that makes yogurt, turns milk into yogurt, requires bacteria. But there are now probiotics sold as tablets or as drinks, and you can take those. There's no problems with the myeloma, but equally there's no evidence that it will benefit the myeloma. I hope that answers the question.
Yeah, no, I think we get often asked a question like that, especially after periods of intensive antibiotics or stem cell transplants. Yeah, great, thank you. Our next question is about monoclonal antibodies. So they are interested in how specific these are for the particular types of myeloma.
Okay, so everybody's myeloma plasma cells are different in that they are by definition not normal plasma cells, and so that they will grow faster or slower. In some people, they'll have smoldering myeloma for decades and their disease remains stable and then suddenly will turn. And sometimes after treatment, plasma cells go down to minimal levels and then sometimes later they wake up. Why it wakes up in 1 year in some people and 10 years in the other, we don't know. So yes, they are different. And the question is a really good one because outside, when we look down the microscope or we even look at the surface of the myeloma cells, they look the same. So it is, that egg looks exactly the same in everybody. And in the same, they have the same proteins. So everyone's myeloma will express CD38, will express BCMA, will express SLAM F7, those 3 receptors that I've talked about, in different amounts. In fact, BCMA is not expressed as well in some people as others. So I really like that question because the CD38 and the SLAM F7 are really quite strongly expressed in virtually everyone's plasma cell, but it doesn't tell us anything about what's inside. So outwardly they look the same, but inwardly we know that patients behave differently. BCMA is expressed in most patients' plasma cells, but not everyone. And in fact, getting onto clinical trials or getting the drug into the future may depend on the bone marrow being assessed, it being looked at expression of BCMA. And there may be, we may learn into the future that patients have to have a certain amount of BCMA for the treatment to be effective. And so we're really in that learning process. So there will be further developments of using these antibodies in different, using the same mechanisms, but perhaps with other antibodies that will be discovered beyond those 3 that I've mentioned.
Yeah, definitely. It's becoming such a individualized treatment.
Yeah.
Yeah, all round. Wonderful question. Thank you. Next question is about lung health. Can myeloma cause irregular or abnormal areas in people's lungs commonly?
Not commonly.
No.
It is, so you can get lung problems. You can get lung problems really by, the most common reason is that the protein that the myeloma produces, so that paraprotein that we measure, sometimes can attack the lungs or sometimes can deposit in the lungs. It's really rare. Usually the protein in patients' myeloma rarely causes significant problems. The most common problem that protein can cause is a thing called amyloid, where the protein can be quite toxic on the kidneys or the nerves or the heart or the liver. But equally, sometimes that protein can cause mischief in the lungs. Sometimes the protein can cause mischief in the kidneys. And so the proteins usually are just junk. They're floating around and they're not causing too many problems. But in some situations, they can affect the lungs. It's rare.
Rare.
It's more the drugs that we use sometimes that can affect the lungs, or infection itself. If people use a lot of steroids, then that affects the lung muscles sometimes, and so it can make breathing difficult if they've been on heavy doses of steroids for a long period of time and they get generalized muscle weakness.
Great, awesome. So really not the myeloma itself, but the actual things that we are giving people to make the myeloma go away. Great. The next question we have is something that I'm sure many people face. When people have many medical complaints or many different doctors and they're getting lots of different advice, how do patients make sure there's no conflict between medications and confusion between medical advice without being, in a difficult situation in the middle? What would you advise that they do to, I guess, aid that conversation between multiple different units?
So it can be challenging. I think the most important thing is realise that you do need to take ownership of your own disease, and that it is important to be reasonably well educated about what's going on. I do recommend patients do try and keep a record of what's happened. So if you do end up going to another doctor, and that doctor may simply be, a gastroenterologist because you've developed reflux or something, but you can go there and you can say, these are the drugs that I've had. Because the most common reason that people draw conclusions which seem incorrect or wrong is because they may just not have all of the information. So they may not be aware that Velcade causes neuropathy, right, or causes nerve damage, and so they prescribe another drug. Or they may not be aware that the patient's on steroids and that's causing their problem. So it's an awareness thing. I think getting opinions from lots of different people and searching for opinions is really difficult for all parties that are involved. I think if you go for a second opinion or you go for another opinion, or you're going from one centre to another and being asked because that other centre offers a clinical trial, then you need to be aware that the second doctor never knows you as well. But equally, the second doctor may give a fresh approach and shine a light onto you that the previous doctor hasn't considered as much. So I don't think any of us feel worried about somebody going for a further or second opinion. Fortunately, in Australia, we're lucky enough that, in the myeloma field, we get on with each other pretty well, and we generally know if clinical trials are available in hospital X and Y, and patients will get referred on. I think that what annoys doctors more than anything else is if they don't know you're seeking a second or third opinion, and therefore they're sort of giving you half, advice in a vacuum. And that's where often it's the best thing to do, number one, is get the doctors to talk to each other. So that should be trying to happen. So bear in mind that the GP sometimes may not know what's going on. So if there's an issue, the GP should really ring your doctor on your behalf. If there are two specialists trying to work out clinical trial or stem cell transplant or whatever, then they should be talking to each other. Be open and don't have conversations. The worst thing you can do is to hide it up and try these two doctors don't meet and know that I'm going and I feel uncomfortable about going for that second opinion. Yeah, it happens. And sometimes you might not even get on with your doctor, and you might sort of say, I don't think he's interested in me and I'm going to look for somebody else who does. That's fair enough, and it happens. But it's important that you go back to Dr. A and say, look, I am moving on because for whatever reason.
Yeah, definitely. All right, thank you for that. Our next question is about, I guess, the differences in benefits between autologous and allograft stem cell transplants. They're interested in knowing when would you choose one over the other, especially in relation to being offered a second stem cell transplant. How, I guess, appropriate and successful are mini allograft transplants, and what centres are commonly doing them in, I guess you could speak to Victoria.
Yeah, look, I mean, we pretty much know what's happening around Australia, but allogeneic transplants, which is where you get a transplant from somebody else, so usually brother or sister or can be unrelated, is a procedure that we've been doing for many, many years for a whole lot of blood cancers, particularly the leukemias. And they definitely are continue to be done for leukemias. The problem when you the principle is a lot about the immune system, because ultimately we used to think that the transplants simply were a way of giving big doses of chemo to somebody and then putting in a fresh bone marrow and no myeloma cells, hopefully the chemo, and basically it's not the chemo killing off the myeloma. It's because there's no chemo that we really know that will kill and ablate myeloma because it stays resistant. But the reason that allografts are successful is because you're putting in a new immune system, that immune system that can then recognize the myeloma as foreign. So all that I was talking about in the last hour about boosting the immune system is the fundamental principle of an allogeneic transplant. Problem goes back to exactly what I was saying with the autoimmune disease and a thing called graft versus host disease, because not only will that new immune system attack the myeloma, it will attack the recipient's gut and skin and cause graft versus host disease, and it can kill the patient. So graft versus host disease in myeloma in the early studies, and be ready for it, used to kill almost 40% of the patients who had that treatment. And still, if used in the wrong patient, mortality rate for an allogeneic transplant can be up to 40%. And that means 4 out of 10 people don't last the first year. So it is not a treatment for the foolhardy or people who are not brave. if chosen appropriately in a young person with the right treatment, the mortality rate can be quite low, 10% or less. That's still, if you don't want to be the 1 in 10. So we don't, whereas a transplant from yourself, the mortality rate is around less than 1 in 500. And in fact, the hospital I've worked at, we haven't had a death from myeloma transplant for the last 7 or 8 years from an upfront transplant. And even in that, and so that's a lot of transplants. So that's well under 1 in 500. So and people have hoped that an allograft will cure patients, and it does in some situations, but it's that risk of toxicity and that 1 in 10 death rate. Getting back to precision medicine, sometimes when we do the myeloma testing on patients, we find that they do have resistance, and so that we know very early on, there's a protein called P53. P53 indicates resistance, myeloma resistance, so it's really tough to kill. And so patients who have this abnormality are unlikely to survive 3 years. So those are the situations. Fortunately, it's extremely rare. It's only 1 to 5% depending on which studies you look at. So the rest of the 97% of people with myeloma don't have this. And so the number of transplants in Victoria for myeloma allografts in Victoria is under 10 per year. It's pretty unusual, and virtually none of those are first line. They always go through your first line treatment, and then at first relapse consider the transplant at first or second relapse. So I'm not anti. I've got patients who I've sent for allografts, but they're highly selective, and they have to be aware of the risks.
Yeah. I think with the development of other drugs and stuff coming out on trial, it's probably going to be even less and less as we move forward as well.
Yeah, you're absolutely right, Laura. I think this is the difficulty with discussing things with patients, is we're trying to predict what's going to happen. And so CAR T cells, people will be definitely offered a CAR T cell approach before a transplant in 3 years. So CAR T cells for myeloma, I've talked about the cost. So which patient will be the challenge, and how much money is allocated by the government will be the big issues.
Definitely. And I imagine it will be those high risk, young types of people that will be the people chosen.
It's hard to know, because equally those people with the good, older disease who have, I agree with you, that's probably going to be definitely a group. But then how do they go further? Like older patients, a 70-year-old with P53 could have CAR T cells and go to 85.
Yeah.
And so that's, and still function extremely well. So that's the challenge. And so in a non-ageist population, and in a population where myeloma is average age is 65 to 70, then I think these sorts of things are not going to be limited by age. And that's going to be interesting, because we always used to use that for medicine in the years gone by, whether that was coronary artery surgery or whatever. Age always was, a cutoff to limit numbers, but it isn't anymore. So it's a difficult one.
Yeah, definitely. Great. Well, thank you for discussing that. Our next question is about we've got steroids and remissions in between cycles of therapy. So this patient has been on carfilzomib or Kyprolis for 4 years and is in complete remission, according to their doctor. They've stopped some steroids, and they've just noticed, though, that their side effects don't recover in between cycles, even though the drug is working for their body. Is this normal, or should they be considering another treatment to improve their side effect profile? Because it's that balance between, working for the myeloma and working for the actual body and how the patient's feeling.
Yeah, no, look, these sorts of questions are what we get challenged with every day, and you can pick any drug. I think that it gets back to this concept of, which is about putting the brake pedal on the myeloma. So one of the things with carfilzomib is that it hasn't been around for that long. I mean, it's been around for 7 or 8 years. And so the trials that are being done now is that how do we use maintenance treatment? So carfilzomib classically is given twice a week, but recent studies have shown that it's just as good when it's given once a week. And then the question is, well, can you give it every fortnight? And so give it as a maintenance treatment. And so I've actually done that with patients where I have stopped the carfilzomib and given them a rest for a few weeks and then come back and given it to them every fortnight, simply because coming into the hospital has been too tough on them. So the answer specifically to this question is that if the side effects are getting too difficult, then you either stretch it out or you can dose reduce. And so another thing we don't know in some people, and it gets back to that individualized issue with myeloma, is some people require much lower doses than others. So I've got some patients who are quite intolerant to carfilzomib, yet are getting quite good responses at very low doses. So we always start at the optimum dose because we don't want to kick ourselves and say, oh, the drug hasn't worked because we haven't given them enough.
Yeah.
If you're worried about a patient, we always start with this dose, but backing down sometimes works quite effectively. And so the answer I'd be saying is that, well, consider if you've been on it for 4 years going to every 2 weeks or reducing the dose.
Yeah, definitely. I think often patients don't understand there is sometimes a lot of room to move within your treatment and its dose and its scheduling, even though it says this is how we should give it. There's a balance that can sometimes be found between the side effects and the actual efficacy of taking that drug. Yeah. Yeah.
Look, I totally agree that's what you say. Balance is really the key word. I just make the other comment that it's a bit tricky in the reimbursement environment that we live in because we are restricted in terms of how we can use these drugs. So, for example, we can't stop carfilzomib and then re-prescribe it a year later.
Yeah.
We can with thalidomide, we can with lenalidomide, but we can't, crazily enough, with pomalidomide or carfilzomib, and we can only use daratumumab once. So our hands are a bit tied in terms of what's approved. So sometimes doctors' decisions about holidays and breaks and things can be influenced by the capacity to get the drug again. Because once you stop carfilzomib, there's no hard and fast rules, but generally it's 6 months or more hard to get you back on it.
Yeah, not always so easy. That's all the time we have today for our questions. If we didn't get to your question today, we apologise, but we will answer it in coming days via email. Thank you so much again, Miles. It was wonderful hearing from you today. Thank you for explaining everything so clearly. I guess thank you to the Myeloma Australia community for being so enthusiastic and making days like this really worthwhile. Thank you to my colleagues at Myeloma Australia for all the assistance in running this event today and over the last few weeks getting prepared for it. And also thank you to the expertise of our production company, ZVP. Definitely a shining light during COVID and something that we will continue to use, I'm sure, far into the future. A reminder to complete the feedback form to help us improve our seminars. And I guess a reminder as well that Myeloma Australia has many other services. I'll run through them quickly now. We have a telephone support line for patients, carers, and anyone affected by myeloma. And this runs between Monday and Friday, 9 a.m. till 5 p.m. Eastern Standard Time by specialist myeloma nurses from across the country. Additionally, we have our resources that are available online and in hard format. If you would like any of them, please email or call our head office. We have many other resources on our website, including previous seminars that you can watch, as well as watching this one. Hopefully it'll be up next week sometime. We run our information and support groups across the country. If you're interested in joining a group, please call head office or contact your local myeloma nurse, or log on via our website and you'll be able to receive information on those. Thank you again, everybody, for tuning in. Hopefully we'll see you in real life next year, but it's been lovely reaching so many more of you today in this format. Have a wonderful weekend.